All right, so our last speaker is Rebecca Williams, who is going to talk about evaluation of the ClinicalTrials.gov results database and its relationship to peer-reviewed literature.
Thank you. So I'm the Assistant Director at ClinicalTrials.gov. The work that I'm presenting today is with the authors that you see listed on the slide. Our primary disclosure is that we depend on ClinicalTrials.gov for our paycheck. I think we all probably across the podium too could have shared the same background slide. I think that the key point here is basically that policies and laws have really impacted the landscape that we currently have available. And the ICMJE policy in 2005 really allowed us to begin getting at a better denominator for what trials are actually available, knowing that the published literature isn't reflective of all of the clinical trials conducted. In 2007, when FDAA was passed, it also further expanded the requirements here in the US for trial registration, and more importantly, it added a requirement to submit summary results information to ClinicalTrials.gov for certain clinical trials. These trials are of FDA-approved drug, biologic, and device products, and there is a requirement to submit these results within 1 year of the completion of the trial. Also of note, just this year at the beginning of 2017, the results reporting requirements have been expanded so that they will include unapproved products as well under the legal requirements. So since the launch of the results database, we have had an intense interest in evaluating and ensuring that it's actually meeting the intended goals that were set out by Congress and the general kind of population. And so at the last Congress, we actually presented a framework that was intended to begin to evaluate if the results database was actually meeting the goals that had been stated. And so one of those goals is clearly to increase the amount of results information that's available to the public. And so in the abstract that you have in your program, we looked at 2 different samples. The first was just a cross-sectional sample looking at all results that were posted on ClinicalTrials.gov. At the time, it was 24,000 studies. We now have 28,000 studies. The key here is that really when results are posted on ClinicalTrials.gov, most often there is not a corresponding publication, and you can read more about those results in the abstract itself. What I really wanted to focus on today is the second sample that we took that's focusing on this concept of a drug family. And really the idea of looking at this drug family sample was to be able to take a perspective that was more in line with how you might be looking for results information, and that you're likely to be looking for information on a specific drug and a specific condition. And so we grouped our trials into what we call drug trial families that represent a single drug, condition, and sponsor. We focused on studies that were registered on ClinicalTrials.gov as of December 2014. We limited it to phase 2 through 4 clinical trials of drug or biologic products with a location in the US, and those studies that were sponsored by industry. We also limited our sample to those studies that completed or terminated in this window of January 2007 to December 2009. We wanted to ensure that we had adequate follow-up for the studies that were included in this family sample. We ended up then taking a convenience sample of those trials that met those inclusion criteria. There were about 3,000 studies in that initial sample, and our sample ended up being about 329 trials grouped into 96 drug trial families. For each trial then, we assessed whether there were results posted on ClinicalTrials.gov or publications available in PubMed, and we looked at this at 2 different dates. We've updated it since also it was published in your program. So we looked in January of 2016 and then again just a month and a half ago. When we looked in July, we also assessed the drug approval status of the products that were the trials that were being reported. And just to make sure that everyone understands this concept of drug trial family, you can see here an example of kind of the groupings of what a family would represent. In the middle, you see a drug trial family number 1, which is representative of 3 different trials. They are all sponsored by Allergan. They are all looking at the drug botulinum toxin type A, should have picked a shorter name, and the condition torticollis. And then another drug trial family is actually the same sponsor, same drug, but a different condition. So those represent unique drug trial families. Focusing first on the results related to the clinical trials themselves, as I said, we had 329 clinical trials in our sample, representing 86 different drug products, 78 conditions, and 45 different companies. And that resulted in 96 unique families. There were about 3 trials per family with a range of anywhere between 2 trials. You had to have a minimum of 2 trials to equal a family unit and a maximum of 11. The results that you see here, again, are the clinical trial, the per clinical trial analysis. And so you can see overall the rates of results reporting for the clinical trials in our sample was 71% when we first looked, and then increasing to 78% when we just checked again in July. What's significant is in that first group, you can see that 33% of trials are represented in ClinicalTrials.gov only, representing nearly half of the trials that had results publicly available. That number dwindles over time as more time is allowed for then the publication process, and results then become available in both publications and in ClinicalTrials.gov. When we looked at the FDA approval status of the drugs that were being studied in the clinical trials, we found that the rate of overall results reporting was higher. So of those trials that had FDA-approved drugs, 86% of those trials had results publicly available. Of those trials that did not have drugs that were FDA-approved, the rate was closer to 60%. And you can see again that about almost a third of the trials in that group were available on ClinicalTrials.gov only. When we looked at the results based on the drug condition sponsor family groups, those 96 families, we grouped it based on whether or not results reporting was complete for the family. So were all trial results available for one particular family? We found that when we most recently looked at the data, about 60% of the families had complete results available, leaving the remainder to either have partial results available for the family or no results available for the family. Some limitations associated with this particular sample is that we only focused on those studies that were registered on ClinicalTrials.gov. We did limit the sample just to those studies that were industry sponsored, trying to keep the trials under the control of one individual, one entity. We did take a convenient sampling approach for that drug family analysis, and we did limit our sample based on a very specific time period of trial completion, that January 2007 to December 2009 period. And that time period also didn't specifically align with the legal requirements for reporting, so it's hard to kind of associate those two things. But in terms of the potential implications of the research, it's really clear that the results database is proving to be a unique source of results information when it isn't otherwise available in the published literature. And I think there's a lot of really interesting questions about how journals and others can leverage that information when it is available. Through the publication process, we've seen a couple really unique examples right now. The New England Journal of Medicine has published 2 articles in which there were a large number of secondary outcome measures, and not all of the results for the secondary outcome measures were reported in that particular publication, but instead the publication referred to ClinicalTrials.gov in order to see the full breadth of those secondary outcome measure results. It's also interesting to think about how journals could leverage the information when it is available on ClinicalTrials.gov for consistency checks, and I think also similar to the outcome measures, referring to adverse event information in the database as well. The overall rate of results availability does seem to be improving, but it was a little bit disappointing to still see that the reporting of a family on its own, we still have incomplete results for these families of drug trials. We're really hoping that with the expansion of the legal requirements, that will continue to expand the availability of results information. This is like on an automatic thing. One of the other, I'll just make another point on the thank you slide. I think one of the other things to consider is the role of journals. When it is known that there is this drug trial family that exists, and if there is one trial that's unreported, what is the role of acknowledging that unreported trial or asking questions about it, or making it known at least that this exists. And I think that's a responsibility of the investigators and the sponsors, potentially as well as the journals. So thank you.
While we're waiting for people to come to the microphone, could you explain families to me? So I'm sorry.
That's why I took extra time, because I had a hard trouble wrapping my head around it too.
I just want to understand, a drug trial family is never just one trial. It's always more than one.
In this analysis, yes, you had to have at least 2 trials to equal a family.
And it's never because you were afraid that maybe it was the same trial 1 and 2 that they were talking about. It was more because it looked like it was sequential.
Yeah, it was more that we were just trying to assess this denominator, sort of what evidence is available on this topic. And so we felt it fairer, I guess, to be looking at more than one, and weren't really sure how that tail of single studies was going to impact the overall result.
So I guess that's the final question I have, which is, why did you feel it was necessary to analyze by families? Was there some potential confounding that?
Well, I think what the families gives you, it's really more, when you are interested in looking at a particular topic, you're typically interested in looking at a particular drug and a particular condition together. And so we wanted to take an approach that was more similar to what you might be doing in real life. When you look at kind of this cross-sectional approach, and even you could see with our clinical trial results, you could see we had, it was, I forget what the exact number is now that I'm moving on, but the results are really different when you group them by trial versus when you group them by family. And when you look at them by family, it gives a better sense of kind of that overall approach within a specific domain.
Okay, at least I
understand
it.
And Deborah, do you have something to add to that?
So another way of thinking about it is part of our evaluation of ClinicalTrials.gov in general goes back to some of the foundational scandals, if you will, to say, could those still happen? And one of those was Paxil. So remember, the issue was that GSK had done, or SmithKline Beecham had done many trials of Paxil for depression in children, but only one was published. Originally one was published. And that was not a random sample of all the trials they had done. So the question was, could that still happen? So that's part of it. So we're looking at a body of studies by the same sponsor on the same topic to see whether ClinicalTrials.gov and the policies surrounding it have improved the situation so that you can no longer do 5 studies and decide which one to publish after you see all the results. That was the thinking.
But I don't want to take away from the other people, but let's say if there isn't a long line, that we'll get back to that question. Okay.
I may be breaking the rules of engagement here, but I'm kind of intrigued with the difference between your results and the results of the previous presentation. And aside from whether something's dealing with an FDA-approved drug or not, but why you have 90 to 100% publication rate in the previous versus what almost everybody else sees. And can you think of any characteristics why that would be the case? I think I may have just gotten an idea what the answer was from that question. But if there is something that makes people much more likely to publish it, do you know what it is and what we could do to try and motivate people to do so?
Yeah, it's a great question. And actually yesterday I was talking to Constance and she had that same anticipatory questions that people may ask us why our results are different. And I said, oh, well, yeah, let's talk about that. So I think a lot of it does actually have to do with our sampling approach. That study was focusing on drugs that had been approved by the FDA. And you could see in our sample, our reporting approached 90% when you took into account the approval status. So I definitely think that was probably one of the main differences. And then also the timeline. We chose studies that overlapped with the time period of implementation of FDA. And so some studies weren't required to report that were included in our sample. So it's kind of hard to tease out those two issues. In terms of the other question, in terms of what the factors are associated with publication, that's a harder one to get at. I think a lot of our experience in working with investigators who have not published and are not planning to publish is just that they haven't taken the time to do it.
Sorry.
Michael Mullins, Washington University in St. Louis. in your slides and in the published abstract, it was not clear exactly what the convenience sample was until but it appears to be the convenience sample is ability to put into a family. And that's fine. A convenience sample is okay as long as people know what the limitation is.
Yeah.
But I'm also curious, just as we learned earlier, that the industry-funded trials are more likely to have some compliance with established guidelines and so forth, because those may represent the CROs or the sponsors having more resources to assure compliance because they want to get publication and so forth. But in the clinical trials database, just as there are a bunch of Allergan or any other company trials, there are also some, we'll say, orphans of entities, researchers, or companies that have one trial that's in ClinicalTrials.gov. I'd be interested to see, to know by comparison what happens with the orphans in ClinicalTrials.gov as well as the families.
Yeah, I agree with you. We would also be interested in understanding that last question in particular, even, you know, within this particular sample of the families, because we limited it to studies that were done by a single sponsor. It's possible that someone at your university could also be doing a study on botulinum toxin type A on torticollis, and how does that affect kind of the overall results and results availability. So I definitely agree in terms of that follow-up. The first question in terms of our convenience sample and approach, yeah, we basically kind of went down the list and started putting things into drug families until we ran out of time. And so that's kind of the way that it went, but there were potentially many other drug families that could have been created from that initial 3,000 trials.
Thank you. So we'll hear about the orphans 4 years from now.
Yeah, exactly. We'll keep following up.
Hilda.
Hilda Bastian, thanks. Just without going into a real lot of detail, how did you search PubMed? So just to get a sense of how likely you were to have found studies that were in PubMed, and then whether you've got any idea how often these studies are published outside PubMed? Mm-hmm.
Yeah, it's a great question. So our methods were first looking at whether or not we actually had a link to the publication in the ClinicalTrials.gov record itself. We automatically include links to publication when that NCT number is indexed in Medline. So if it was there, and it appeared to be a match, then we actually went to the publication to verify that it was actually the results of the clinical trial, because sometimes it is possible that the links that are added are not necessarily the results. Sponsors and investigators can also manually add to the study record their own links to publications, and it could be background information also, so it definitely did require verification. And then we use basically key information from the study record itself to verify the information in PubMed, so looking at the investigator name, the drug, the condition, and I can't remember all of the other items, but we have described that in other research that we've done as well. Break the rule, go for it. No.
This goes back to the question of one of the differences between our study and also between my study and other studies that reporting drugs approved a similar period. I think one of the differences I may venture to guess is that I utilize the Google Scholar to triangle PubMed record. PubMed, I love PubMed, but one of the barrier for me to search in PubMed is that when the search is only limited to the title and abstract, sometimes the characteristics that I'm searching for is in the documents and the full text. And so Google Scholar have a variety of PDF full text submitted by people to like ResearchGate.com or other websites. So they allows me to identify. And once I found the correct title, it goes back to PubMed, and I was able to find all of them in the PubMed.
Thank you. Go ahead, Gerben.
Gerben de Riet, University of Amsterdam. Thanks for an intriguing talk. I also struggled, like Kay Dickerson, with the concept of a drug trial family. And so it suddenly reminded me of a paper by Ioannidis and Carissa in the BMJ of 2010, where they advise people that do systematic reviews to look at the wider research agenda. And so let me just read what they say. They say, when an intervention shows effectiveness for only a tiny fraction of tested indications, seemingly promising results may be false positives. So to me that means that maybe we should even look at larger concepts and drug families, but look at whole fields of indications that pharma industry might be doing research on. So my question to you is, could we exploit ClinicalTrials.gov maybe in a more extensive way to follow that advice?
The simple answer is yes. Great idea.
Let's collaborate then.
I had a question, Becky, that, and it's unrelated to, I think, what's been said so far. You added at the end something that I thought was sort of intriguing based on something I think we heard yesterday, although I lost all track of time. And that was about supplementary information, that you thought maybe this was a place it could go. And we heard yesterday that the supplementary information that's online at journals can take up a lot of room. So are you working with any journals, or is that what you're saying, is maybe the supplementary information that's now online at the journals could go to ClinicalTrials.gov? Because it seems to me we're putting information in so many places that it's tough on the person just trying to figure out what to use. So is that what you were talking about?
Yeah, absolutely. And I think one of the slides, actually I don't think Deborah included it in her slides yesterday, but she referred to it, is that we do like to think about ClinicalTrials.gov as a potential scaffold in which to hang things off of. And because, you know, we link to journal publications and journal publications link back to us, it seems like a very natural fit to leverage those connections to be able to show the data that can't be shown in each of the different sources alone. And especially now that we have the ability to accept protocols and have those available also, it will continue to be a really rich source of data. So really thinking about how these things can be complementary to each other.
And are you working with any journals or other places just to make sure we don't have studies showing disagreement in protocol, supplementary information, et cetera, that in fact the same information is two places or one place?
I think, you know, we definitely in this case, you know, had some interaction with the journal, and I think this serves as a good model, and we're happy to talk with anyone at any point in time in terms of how best to approach this. And there's always the potential to write up kind of an SOP when thinking about different things like this and how to make it easier for all to follow it.
Okay, thank you. Any other questions for any of our speakers? Anything about trial registration? You've got the experts in front of you, so. Okay, well now then, thank you very much for your talk.